So the next 3 minutes, just at your table, come up with a specific barrier to implementing whatever it is that you want to implement. All right, so who wants to go first from the tables? All right, we have a winner.
Well, I think we said before in California we don't have long-term continuous enrollment, which makes it hard to invest deeply into any one patient. So that's the big barrier. And then we're a payer. We can't directly implement a clinic like you have, but we do have some ideas to partner.
So what can you do without structural change at the state in order to fix that as a payer?
Oh, nothing.
I don't know. So I disagree. It's always a solution. And so one of those solutions... Rhetorical for you, not for me. I don't know the meaning of rhetorical. I think that's pretty obvious at this point. If we... Shelly's... I'm going to require a therapy session later. That's right. So one of the things that you can do, and we've toyed with this at our payer, Priority Health, our CMO, who I actually would recommend, those of you who are from payers, Jay Labine is the CMO for Priority Health Medicaid, and he really is a champion of our clinic, and he took over after we had already started the clinic, but really from the payer side has helped push things along, because if you look at who owns the savings, it's actually the qualified health plan for this, but the medical group just loses money unless we have a break-even margin. So being able to say that they'll help offset, so he really understands the idiosyncrasies from the health plan side as the CMO, but we've talked about this very thing. And you can incentivize patients to stay with your product. So you can incentivize patients to stay with your product based on copay requirements, based on access to certain treatment pathways that are above what's required, as well as even direct payments. And that's within there. So you can actually, if you stay with our product for 3 years, we will give you $500. So that right there pays for itself, because that amount of money, when you can actually do meaningful work with the patient, does it. So these are things that are legal, at least in our state and at the federal level. You can't entice them up front to take your product, because that's illegal. So you can't say, I'll give you $500 if you sign up with us. But you can for retention purposes, and we looked at this from the federal level and from our very conservative legal team at Spectrum Health said that they couldn't find any reason that by itself wasn't legal to help entice people to stay within the product over a period of time. And you can do that. You can, from the providers that you contract with, like us, when they come to our clinic, they only really get treated because they have that payer now. And so, because we only take 2 payers, if you're one of the super utilizers, the high utilizers of the ER, or pregnant on a controlled substance, or admitted 3 or more times per year. And if you change payers, and we tell our patients this, if you change your payer, we can no longer see you, because we will have to figure out how to get you set up with another primary care office. It's not a threat, it's just reality, because the other ones, we otherwise can't get paid for what we do, and then we can't keep our doors open. And so you can work both from the top down from a payer, from the bottom up in that setting, to eliminate that barrier without an actual structural state change that would allow for that churn to decrease. All right, next barrier.
I'm just wondering how you address housing in your program. You mentioned Maslow's hierarchy of needs and not being able to kind of get higher on that. And we certainly have that, especially in the Bay Area with rents just going up, the subsidies not being able to help as much as they could in the past, and really having a lot of challenge getting through the housing barrier before we can address more of the clinical issues.
Yeah. So I bought a table saw, and I'm planning on building housing. No, so this is the biggest issue in the country. Because we recognize the cost savings by having transitional and even medium to long-term housing placement for patients. The problem is that unlike services, this actually requires initial capital outlay. Because vouchers don't work in a setting where they can get a huge amount of a higher level of rent. So even vouchers for Section 8 or for other types of transitional housing don't work. And generally, they're not very therapeutic because they're disconnected. So HUD did some research that showed that the best way that you get people to improve in their life is to disconnect, put them out into a neighborhood that's not their own, into one that's doing better, and disconnected housing and not having housing projects. However, what they didn't realize was that's only after they're stable. So initial housing is different than medium-term and long-term housing. And so initial housing is like a sobriety house, so that they can be somewhere where they can actually be around people in a therapeutic environment before we fully disconnect them. Because we find that if we take a patient and get them an apartment by themselves, they still drink themselves silly. But if I have them in a therapeutic housing situation, they generally don't. So handling transitional housing is who actually needs it versus who has it. And that's a real difficult problem to answer, because my pregnant patients really need transitional housing because most of them are in situations that are violent. And I don't have yet, now we're about to, with the Salvation Army, actually build transitional housing units just specifically for our pregnant population that will be able to hold during and for 6 months after pregnancy our pregnant patients. So when they come in, we'll have a place for them. So short of a capital infusion campaign, we're calling Elon to see if instead of a rapid tube transfer system, he can help you build something helpful like housing. That would be cool. I mean, but this is where we have to, as a community, start to say this is what we need and make it a very loud offer. Because a lot of us say it in passing. In these conversations, we have the conversation, but who at the table can actually affect that change? You know, the Chamber of Commerce can make those changes. The city can rezone areas so that they can be utilized appropriately. You know, they can actually create housing vouchers not only at the lowest level, but to match federal housing capability. So there are ways to do it, and there are people who do it in little pieces. You know, Housing First has been a very positive impact pathway, but it's actually paperwork first rather than housing first. And so trying to see how we can decrease the burden on the patient for some of the filtration and just get them a place. Taking a shelter and taking, 5 of those beds and actually transitioning those into dormitory units rather than just cots, so that people can have transitional housing that's their own place, that they can lock a door and keep their own stuff if they earn that right to be there for that period of time through sobriety and continued, work within that environment. So there are a lot of little things that I've seen around the country that help in little ways, but big ways, we need brick and mortar. Unless all of us are going to say tomorrow that we're going to loan out our basement. And I'm not loaning out my basement.
So I'm going to give you the social work answer now that the wordy doc is done. It's a huge issue that we haven't really been able to resolve in our community. And so what do? Day by day. And we try to provide as much safety. For the one big thing we can do for our patients who don't have housing and who we can't find housing for because they have multiple felonies or evictions, et cetera, because all of our Section 8 waiting lists are all closed. So we have med lockers. So our patients who have medications, whether they're on buprenorphine or other meds, they actually store their meds in our facility, and then they have to come in every day and get them, or every other day. That's helpful, because then we can see them. They have a safe place. A lot of times when we come in the morning, 2 of our homeless patients are sitting in there having coffee. I walked in the other day, and one of them has seizures from his drinking, and the whole side of his face is all cut up because he was falling. And I could tell just by looking at it, it was really infected. So I walked in late to the morning meeting, like I always do. And I said, hey, someone needs to look at his face. I can tell it's infected. And sure enough, it was. And those are the kinds of things that it doesn't fix the problem, but at least that connection helps the patient.
Yeah, so definitely if you want them to maintain, and you have to be specific because the laws around housing some patients' medication are really important to understand. Because if you put them in behind your closed door, it counts as redistribution of medications. But if you actually have them have unfettered access to those and what's in the locker is theirs, then it actually is not a redistribution. So you have to be very specific. They have to know that, and you have to have these conversations. We had talked with our local DEA to see what we could do about this, because I knew one of the another clinic had tried to store it, but they stored it in their safe where they stored it was a methadone clinic, and they stored it in there. Well, the patient didn't have access to that, and they would bar the access, and so it was seen as redistribution. So you can put lockers that are basically theirs, and then as soon as you open, all of that stuff is available. But what it does do is if you have a patient who wants to use their meds for something other than prescribed, they have to ask you for the key. You're going to give it to them, but you're going to have somebody walk with them over to the door as we do it. We're going to have a conversation as we open the locker. We're going to talk through some of these things. We're not going to stop them from taking them unless we feel that there's a significant risk of like, I'm going to take all my meds and kill myself. Well, all right, fine. We're going to probably stop that. But the reality is they don't say that. They don't tell you if they're really going to try it. They tell you when they're borderline and they're actually not going to do it. But having these little things other than housing is helpful. So making sure that you have the ability to wash clothes, making sure that you have the ability to get them new clothing, showers, to be able to do this. Those are ways that we can mitigate not having housing. It's actually a mortality rate issue in Michigan because, we have a pretty significant winter and we have, patients die every year, in the winter. And we really try our best to make sure that they know that we have housing. So we probably have more shelter housing per patient than you guys do because of the winter. And so they really beef up the shelter capability to clean the streets. And the police actually give some money to the shelters as well out of their budget. Fire gives some money out of their budget. So a lot of these people that have less calls and they have to staff less give money out of their budget so that they don't have to get called for found down, on the side of the street. And from that, they decrease their level of work as well as get appropriate housing. So if you get everybody to pitch in, a little bit from everybody makes a big difference for that. And I find also right now with social impact bonds, this is a really helpful thing to take all this money sitting out there that has nowhere to be invested. And believe it or not, there's billions and billions and billions of dollars that are sitting out there just looking for a place to be invested. And most of these are available through social impact bond pathways where somebody buys a bond for something of social impact and all they really get in return if there's is the fact that they had a social impact. I mean, they're going to pay it in taxes anyway, so for them this ends up being a nice pre-tax deduction, and so you can buy those bonds as a social impact and then they get a tax deduction for it that matches what they needed from their contribution. So there are ways to do it, but it takes a lot of work on our side. It doesn't just, housing doesn't just erect. Yes.
So I just wanted to share that Yolo County came up with a somewhat innovative solution to the housing problem that I'll share. I don't have a lot of details because I'm not from Yolo County, but what they did was take over a low-rent motel and moved all of their homeless from the riverbank into the motel along with all their animals, because you have to have the animals too.
Yeah.
And because they were moving them off of public land, they were able to give them vouchers that were based on being evicted by the government, which moved them up on the voucher list, so that after a few months, they had almost all of them into public housing of some kind on their vouchers.
Yeah, no, I think that those are things that we need to identify if they're scalable, and if they are, scale them as rapidly as possible. In San Antonio, they actually built basically a campus for these patients just right outside of the city where they have still outdoor housing. So basically an outdoor shelter for those people who just don't want to be in a shelter, because there are some that just they don't feel comfortable in those settings, and they just had covered areas on the outside and they could store their belongings in a locker right next to them. And they actually had places for their animals to go to. So they had kennels for the dogs, and they would help for all of the animals that they have, because it is the only thing that they've ever been able to count on, quite honestly. And then if they wanted to move up through the housing, they would let them, but not make them. And so they've done a good job in San Antonio as well, but that was a single benefactor who bought some land. But they have the full continuum in that one place, and it literally looks like a college campus. And it's pretty amazing. When I went there, I felt very insignificant in the little niche that we had filled based on what they had done, but short of $1 billion investment, which is basically what they had gotten to build that. Things like taking over a derelict motel and making sure that you maintain it, but understanding how is that paid for on an ongoing basis? Because most of these are just people doing this out of the goodness of their heart, and the living conditions are terrible, and they're probably barely even safe, and risk of violence and all of these. So it's one of the very few problems in our healthcare system that actually money would take care of. Most things, it's not a matter of spending more money, it's spending money in the right way, but this is one of those that actually just adding money would be helpful. Next barrier, or there was a follow-up?
I hope this isn't pushing the envelope too far, but has a conversation occurred at all between the medical community and local communities who have housing problems? So I know a lot of our communities here are struggling with the lack of housing, and a conversation where policy could be changed on a local level, like county conversation or with cities, to get some of this funding you were just talking about, which I haven't heard about, but there could be policy conversations around housing with the medical community and the housing communities. Has that ever happened, or?
Yeah, no, those things occur on a relatively regular basis. It's just actually getting to an agreement, because people who don't work in the medical field see housing as a handout. They don't see it as the first step of actually getting somebody well, and without it there. So when you work in certain communities where they feel like, well, we're already giving them things like, food sometimes, and why else would we want to do that? I mean, honestly, those are the conversations that happen when you go to a city council meeting and you're trying to push something like a social impact bond package, because it's something they would need to approve, the city would underwrite, and then it would go forward. But the ones that have been able to do this, they've actually had good outcomes. But we have to rebrand homelessness, because I was homeless for 6 months in college and slept in my Firebird. But that's not the same thing as what I'm talking about. So my roommate gambled away his version of the rent, and I got kicked out and didn't have enough for, another deposit. But I ate at the restaurant that I worked at as a waiter, and I showered in the gym at my college. So whatever. I was 21, so I was like, didn't seem like homeless. But around here, you have a lot of that. That's actually, you have kind of the working, kind of semi-couching it everywhere homeless as just a part of a kind of a normal transition in life in a place where, it's $400 a square foot to actually get a place. And then versus homelessness secondary to an ailment or a disease. So what we're looking at is no different than a prescription for a medication that decreases morbidity and mortality. And so we have to start looking at homelessness just like a medication, just like a therapy. Because without it, the rest of this stuff is, again, just burning money. And it's wasted money if I give them a prescription that they're going to lose 15 feet out of the door. And if I'm going to want to control their diabetes so they don't end up in the ER with DKA, that means they need the prescription for housing no differently than they need a prescription for insulin. So changing how we talk about these things and creating an appropriate understanding of it is important. And the payers that actually give housing, and there's one in Massachusetts that does a really good job with this, and they see housing as a medical benefit, and they actually pay for housing for their highest cost patients, and it cut their total cost of care by almost 50%, and the ROI per dollar was $2.30 per dollar spent on housing. So, and that data's out there, and it's actually been out there for a while, so we kind of know this. It's just a matter of getting the will internally to make the decision that housing is a medical problem, rather than a social problem. Understanding that these are all directly interconnected, not even indirectly, but directly interconnected is one of the biggest issues. And those conversations happen, but they rarely end up in actual action. See a hand in the middle back table.
So our issue is scale. We're a small rural FQHC, and we certainly have a high percentage of our patients who have mental health and substance abuse disorders, but in terms of patient volume, we don't have enough to carve out dedicated staff that only serves those patients. And as you've pointed out today several times, that having the right personality types to serve those may not be best in the primary care setting. It may not be the same thing. How do you address that?
I think you have to address it with what you do have availability to. And so what you do is you find your most motivated versions of those people, and that becomes a portion of their panel. And so they have their total panel size, instead of 1,500 or 2,000 patients, would ultimately just be 750 patients, but 200 of those would be these very difficult patients. And then they would have the regular ones that they see every 6 months or a year that they would go. But then that's the panel that's the group that those patients go to. And so even within a clinic setting, you can identify those and that would do better. And in the rural area, I think this is pretty much the only way we're going to handle this problem, is to be able to move it out of we need a dedicated clinic, because you need one of our clinics per about 1 million people is what we've been able to kind of look at mathematically for the number of people who are super utilizers versus would benefit from a clinic like this. Out of 1 million people, we're going to be able to max out at 600 to 900 people within our clinic, and that's about the number that would need that service. on a long-term basis. And then after a while, you'll have some that matriculate and some that come in, and so you'll hit that steady state. So if you don't have 1 million people, then it's hard for me to actually justify having something exactly like our clinic. So the variations on the theme are burying it within a family medicine clinic so that you can have a PA or a nurse practitioner associated with an LMSW and some extra case management availability, and connected with the payer very closely, the most common payer that you have, so that they can get help with prior authorizations and things like that. That's the fastest way to do it. If you're in a really rural area where all you have is a critical access hospital, then what you do is you go in and talk with the emergency medicine providers, and you talk with the hospital system and say, what if you guys hired an LMSW, and then we schedule it, and we found the 1 or 2 docs that staff this hospital that actually live in the region? Because there's a lot of moonlighters, right, that come in, but there's always 1 or 2 that like live there. And you find those 1 or 2 docs that live there, and you train them up on the basics of what they need to know, because every morning in a critical access hospital, you're watching The Price is Right and eating breakfast. I mean, I moonlight in some of these hospitals, and you go out, and the morning time is not time used, but you're paying for it, and you're paying for that person to be available there for somebody to walk in an emergency, but it's completely dead. And so if you put an LMSW in that critical access hospital and allowed your primary care doctors to have that as a referral pathway, now you can actually refer patients on a regular basis to the LMSW, but you also have them in the ER for those super utilizers who could then be seen by that ER doc, who could then also write buprenorphine for a few of those, or give Vivitrol injections, or camprosate for alcohol, or those things. But use the hospital, because you don't have to build anything, because they can pee at the door too. You can do the toxicology studies. If they need lab work or a workup, you can do all those things. And they're obviously used to being there because they're ED high utilizers.
So Corey, we had a question about help for providers in rural areas. Could you talk a little bit of how you've used ECHO or other telementoring options to get skills to people who couldn't necessarily come in for a training?
Yeah, so I did 4 weeks in a row set up a day, like on every Wednesday for an hour and a half, and not really anybody was coming onto that call within our group. And so what I did was went back out and just said, here's my number, call me if you need me. And that actually worked out better for our group, because everybody had lunches at different times and this and that. But now they're wanting more of an actual education along with it, so we're going to go back more closely aligned with the ECHO model. But for right now, I get probably 30 phone calls a week from primary care doctors. And we're trying to formalize this in that package of the PA nurse practitioner, the PA or nurse practitioner with the LMSW out in rural primary care, have them vertically aligned within the clinic setting, that they're, so the primary care doctor, but then laterally aligned with our clinic. So they're really connected to our clinic, and actually just a remote portion of our clinic buried out there somewhere, so that we can talk with them on a regular basis, run patients with them in the morning. They're a part of our workflow. And I think that replacing some of even the ECHO is by really connecting with those people in the clinic as just an extended part of our central clinic, allows us to then move that information out there, and then they become the expert locally, and then that ultimately allows them to answer questions for people within that clinic.
So Corey, I think a lot of people don't know what ECHO is. Could you briefly say what ECHO is and how it's different from what you're trying to do with this lateral connection?
Yeah, so ECHO started in New Mexico, and they started it for behavioral health and psychiatry, and then what they did was every week they would do a 1 to 2 hour session on the phone, which doctors could then sign into, and then they would give a case presentation and then answer questions. And then that very quickly turned into more and more time available online to do really direct telephonic consultation for a lot of people, along with the teaching that they did. And now it's gone from just behavioral health to pain to neurology to hematology to GI and all of these different ones. And it's now, you guys have an ECHO pain project actually here in California that goes up and down the coast. And I know that they use that up in Humboldt and Eureka to interact on a relatively regular basis. So those are one ways, but we also already have an ECHO project version nationally called PCSS. And so PCSS-O and PCSS-B are basically the availability through the American Society of Addiction Medicine and SAMHSA to have a mentor that you can have assigned to you if you're writing for buprenorphine or even now opioids. And so you can sign up for this, and you'll have an expert mentor that will be connected to you to help answer those questions. So you don't even have to figure out how to develop it locally. It already exists nationally. and you can get signed up for that by itself, PCSS, or go through ASAM or APA or any of those to get connected with that. And they do have, and when I say mentor, I mean it. So you can just talk with them about not just a case, but just like, how do I onboard this, and what do I do, and what are my issues with this, and I'm worried about this or that. And you can actually have a conversation with someone who does it for a living. And they also have monthly webinars that they give. And that information is very directed at very patient case-specific types of interventions. And so that PCSS capability is available for anyone who wants it for free. I mean, so it's funded by SAMHSA, and it's funded by that, so you don't have to like pay a fee or anything like that. But then a lot of these things are also available on online educational packages through like American Society of Addiction Medicine, which actually now is accepting licensed master's level professionals as members of the American Society of Addiction Medicine, recognizing that it is a team sport to treat addiction. But so there are a lot of things out there to help with the onboarding of the education. I mean, we're developing this complex.care, which will have a lot of these things in a pretty sophisticated way once we get it done. But there's already a lot available. It's just trying to figure out which one fits you.
I just have a question based on that critical access thing you just talked about. How would you make that a visit? You have your ER doctor who's on staff. That's not an ER visit.
Nope.
Can you describe how you would do that?
You
and
can,
how
and
is
so-
the doctor able to prescribe when it's not an ER visit?
Yeah, so you can actually, the hospital can choose how it bills for a visit type. And so you just have to work with the staffing agency to say when we see these patients that'll get billed out as ultimately a primary care visit or an urgent care visit. So the hospital can always down bill. So if you're bringing them in, that's actually a stark violation anyway if you try to bring them into the emergency department for an appointment, and that's been tested in a couple of ways. But if you bill it out as an urgent care follow-up visit or as a primary care visit, that's perfectly fine. And that's actually been tested through ED follow-up programs where they would set aside, like if you started somebody on Lovenox and you want to flip them over to Coumadin, and they don't have a primary yet or they're trying to get in, you could set that up in an urgent care and you could bill it out as an urgent care visit. You just couldn't bill it out as an emergent 992.5 code. So you just have to bill it correctly, and then it's perfectly fine. And the nice thing about that is if you have a bunch of primary cares who want access to a therapist, which they always say, I don't have access, I don't have access, I don't have access, you can quickly fill up the docket of that therapist so that the hospital ends up making a little bit of a profit off of that person because they don't have to build brick and mortar. They just put them in a room next to the ER so that they can talk to their patients, and they can be roomed by the same MAs that are rooming patients in the emergency department. So there's a lot of overlapping work that can be done in the same setting, and you just have to agree on the billing structure.
So there's a question about, and I'll get to Clayton, about what kind of dashboard do you use to show that you're both being clinically effective and cost effective, and where do you get your data?
So we had a really nice MicroStrategy platform that we had built back in 2007 that allowed me to look at ED utilization, number of labs that were drawn, which bed they were in the emergency department, which providers saw them, and if they gave them opioids, and if they ordered an x-ray and a CAT scan. And then my system stopped paying for MicroStrategy about 4 months ago. So 4 months ago, my dashboard went dark. And I was able to run massive data arrays on this stuff, and we could look at actual all charges as they went in. And then we could break it up by payer, and we knew the general percentage of reimbursement per payer, so we could get pretty close, and then we could monitor that. And we were running those reports monthly on patients so that we could watch it. And then there was an IT decision made without a phone call to me, which I would expect because they knew it was a purposeful non-phone call to me. And then all of a sudden, MicroStrategy didn't work anymore. And so then now I'm in the process of multiple meetings. And however, I did find a new way to talk about this so that it's just not data I need, but it's data we need. And it's data that we need to look at for quality and risk. So you can always jump on the quality risk bandwagon, and you're more likely to get a dashboard built and actually a lot of stuff done. But from a quality and risk standpoint, it's a pretty easy sell to state that, well, there have now been 3 lawsuits successful for suing doctors for making them addicted to medications, which were multi-million-dollar lawsuits and generally tied to the health system they were connected with. So we should probably get an idea of which providers are actually writing for these at a high rate and a per person rate, and how many are writing for benzos and opioids and this. And we should also look at utilization, because that would be really helpful to know if we're not meeting the HEDIS measure for outpatient follow-up and care coordination. So now we're actually going to get a better one, but you just had to kind of rebrand it a little bit and how you approach it. The rebrand very specifically is that we just need to know this. I mean, we're a massive integrated care system, and so the things that we look at for dashboards that I care about are repeat utilization of the emergency department and make sure we're addressing that. If they use our emergency department, we can see it. If they don't, we can go into our health information exchange called Viper, the Virtual Integrated Patient Record, which can give us some lab and x-ray data and the ADT feeds, the admit, discharge, and transfer feeds. That goes up and down, oddly enough. It's really well built, but there's been kind of some risk and quality questions back and forth about flow of information and what's available, and some hospitals will pull back and add on. So it's still a little sketchy for full implementation, but that in theory gives us the big picture for that. But we still have to take that data and put it in an Excel spreadsheet, which is hard work. I mean, that shouldn't be that way. We have Epic, so anything in our system, we can just run a report, and so we run reports based on that. Right now, I can look at ED utilization, inpatient stays, positive urine drug screens for something other than prescribed. We can look at those percentage of patients on buprenorphine also being written for that. And I just now can look at a report for all of our primary care providers of per patient opioid utilization, benzo utilization, and stimulant utilization as a marker for the system and how well it's using controlled substances within the system. Pretty scary report, by the way. You found some outliers that are well-known doctors. So here's what do you do when you find one of the doctors who's well-liked by patients via, now I know why, you know. But also is well-liked by administration and has been a trusted member of the faculty for 30 years. And as the chief of pain, medical staff chief of pain medicine, what is my role when I find this? When I know that they're misallocating controlled substances, but yet they have this history and that. I mean, those are hard questions to answer from a ground level, but once we get this data, we also have to be prepared to act on it. And so I use my style, which is I call them and I'm like, the hell, man? I mean, are you aware of this? I mean, because some people aren't, by the way. Some people just kind of were nice enough to see these patients, and it just slowly crept up over the last few years, back when we had good data to show that you can just write opioids with no risk, back in the late 90s and early 2000s. And everybody's aware that the 4 doctors who wrote that Purdue-funded study, 3 of which are in jail and all 4 lost their license. Everybody is aware of that. I mean, that study came out and disappeared pretty quickly, but this and that $100 million Purdue Pharma fine that they quietly paid, and it went away back in 2002, I think, because they paid for that study, and they paid specifically for that data to be shown as compared to the real data.
And can you say which study exactly are you talking about?
So this was risk mitigation and utilization of opioids for non-chronic pain. And this was back in 98 is when the first study came out. It was in JAMA. And basically it stated that for any dose of opioids for the use in patients with chronic non-malignant pain, the risk of addiction is less than 1%.
Right.
That's not true. And it wasn't just because they picked a bad match of patients or it was bad study design. It was actually falsified data. And so that's what got pain as the 5th vital sign kind of pathway, and that's what ultimately made us all feel comfortable writing opioids for this. So for those of you new into medicine, we had data back then to say that this was that, and it was out of a very trusted journal from an article that was later retracted. Damage done though, right? And so these are huge issues that we're having to live with now. It's probably closer to 50 to 60% of patients on chronic opioids for non-malignant pain that start to have at least complex dependence. And there's actually a neurobiological reason for that. Getting totally in the weeds, so if I get too far off track, let me know. This is fun for me though, because it makes sense, because the opioid system is involved in kind of the basic craving cycle for most things, because most of the brain and its happiness is leveled within a combination of serotonin, opioid, and GABA. And so when you override this system for a period of time, it compensates by also lowering the other drive systems, because this one's turned up too high. And so now when we have this, all of a sudden now we don't have the normal emotional buffer systems that we used to. And so we start to have behavior that looks a lot like addiction because it's not thought through, it's not risk evaluated. And they'll make a quick decision without, impulse control issues start to arise, overtaking meds when they really didn't in the past. They're not trying to get high, they're not doing that, but maybe early refills. And so that very complex dependence just happens as a pathology of this medication over time. And so it's probably 50 or 60% of people who are at risk for developing at minimum complex dependence, and then probably 17% hard addiction, and then probably 25% for really maladaptive utilization of the medications that have risk of accidental death. So, this is where we're having to come back from as we really develop these systems about pain and understanding pain. So just because a doctor has written for all of these things and they've been around for 30 years, they were following data, science, and math, and now they have to figure out how to have a conversation with the patients they've seen for that 30 years and explain to them that what they did for them for the last decade was wrong. That's hard. That's a really hard conversation to have with an office full of patients who trust you and love you and feel like you can't make a bad decision, to sit down and tell them you made a bad decision. And then try to, because we'll do what we always do and try to backward justify it. But there was data and there was this. They don't care. We gave them hyperalgesia. We gave them a labile emotional status. We messed up their sleep cycles. We gave them chronic constipation, which gave them, diverticulitis. So we've done all of these things with these medications over time. And so it's had a lot of actual physical ailments that are going to be permanent for a lot of patients. And so even if you come back and admit that you were wrong, there's a real issue of trust that's going to go away and has to be rebuilt in this current system. So just be careful. Once you get the data, you can want all the data, but you have to really sit down in an ethical way and have a conversation about how you're going to use it.
I'm sorry, I have to respond to that.
Okay.
I disagree with one part of what you said.
Sure.
It is absolutely important to admit that you did something that was harmful.
I agree with that, yeah.
But the part about that you were wrong, you relied on data that was the best data at the time. Turns out those data were wrong. And so I think it's important to be clear with the patient that you didn't do something that was irresponsible. You were doing the best you could with the data then. Now you have different data. Turns out that data that I relied on to advise you 10 years ago was wrong data, was bad data. Today we have different data. So I'm telling you this now. I'm sorry we had bad data.
Right.
And I think that's an important difference, because when you talk about rebuilding trust,
Yeah.
I'm not asking the patient to forgive me for bad judgment. I'm asking the patient to forgive me for perhaps not questioning data as much as I should have, but it was the data that we all had at the time.
And so I think that we need to record that and give that to most doctors, because what happens is that instead of having that appropriate, empathetic, real conversation with the patient, what you get is, well, we can't write you for opioids anymore. And actually, I'm now, as an office, deciding not to write opioids at all, because I just don't even want on that boat. And they'll send out a letter stating that they're no longer going to write opioids. And here's a list of 7 doctors who might. Yeah. I mean, but this is unfortunately, and so when I state wrong, if it's not explained right, that's the perception of the patient. Because many times we get, from a physician standpoint, we get very defensive, about if they come back angry, which, they have every right to be frustrated. They have every right to actually be angry and then rely on us to explain why that anger should be, not necessarily directed at us, because we tried our best. We really did. I mean, we actually read the journal. I mean, that should be one thing. We actually took the time to look at it. And at that time, there were 3 studies that showed kind of the same thing. They were all by the same doctors, out of the same shop, all about oxycodone. But at the same time, it was like, this was still at the beginning of really evidence-based medicine as we know it now. So we also weren't really good as a general field of doing it. But that's a hard conversation to have with a patient with an IQ at 90. Well, I mean, honestly, when I'm looking at real, the real patient, rubber meets the road, they're just going to feel like they were wrong because they're getting something taken away from them.
Absolutely. But we have the same discussion about hypertension based on some data that have just come out this year. We have the same conversation when it comes to diabetes
Right.
because we have new data. So I would submit, especially as a psychiatrist, that there's not a need necessarily to be defensive, although we as physicians often are, but it's a real conversation based on a change in data. And I think it's really important to have that be part of the conversation so that we don't misfocus.
No, yeah.
I think the biggest difference in those conversations, though, is when you have a conversation about hypertension or diabetes, you aren't going to get the emotional response from the patient that you are when you have a conversation about medication, especially narcotics.
Opioids are
And so the minute you start having that conversation with a patient about, well, we have to cut your narcotics or stop them, like a lot of physicians do, you get, like I explain it to my social work colleagues, that midbrain, the animal brain just kicks in and you're in survival mode, really, and then you're not thinking rationally. You have all these escalating behaviors. Primary care doesn't want to deal with it because they really don't have anyone in the office to help. So it's just better to not address.
And I agree with you. I think that we're the one who make them out to be dependent, and then now we label them addict, and then we stop taking care of it. So I think that's the issue. I'm going to switch here a little bit. I want to hear the two of you to talk a bit more about how you interface with the carved out systems. And you have case manager, and those carved out systems also have case manager. Who coordinate all the case manager together?
I thought we were on our own island.
Well, we are pretty much. And so if somebody already
That was a
has, so we don't get dollars. So the structure of the clinic is this. We have the clinical side, which is the prescribers. Then we also have MAs, medical assistants, and the staff that then are the administrators for the office and a front desk person that are paid for by the hospital system. We have our master's level therapists, 4 of those, that are paid for by the carve-out. They just pay their salaries, and that they're embedded into the clinic. Now, this is truly like a connection between the physical health and the mental health system, is that, and then we just have a contractual relationship between each other, because the vast majority of our patients meet criteria to be seen within the community mental health. Not all of them. And so really this is just a way for them to deliver direct care to their patient while also being directly involved with this. The problem with that is that because we also don't see some patients that would be under the community mental health, they want to get reimbursed for what we fee for serviced out, which they should get reimbursed for that because they're covering the total cost. I'm having some interactions with my finance people in Upline about why this wasn't being paid right now, because they saw it as gravy. And so having to have that that conversation up front would have been something I would have gone back and done. So coming up front, you have to be very clear about, we bill for everything for our social workers, and anything we collect should just go right back to the CMH to offset the cost of the social workers. One of the areas, when I built the episode of care payment model, it was purely built to cover the cost of everything but the social workers. So the current episode of care payment model that they're paying really just includes the medical piece of that. And the numbers that I showed you earlier are not what we currently get reimbursed. Those are the numbers we would need to get reimbursed in order to pay our bills if we also covered behavioral health. So it's still pretty cheap. When you saw the complication index, I mean, you have to have almost all of that in order to get to a level 3. I mean, so you have to be like broken in many areas with a very high score to get to a level 3 on that, to get to 5,000 per year, which then covers all of that. I don't get paid by CMH. I'm not paneled with our community mental health or our CA, despite being the medical director, because that requires an RFA, an RFP, assessment of need, and a bid process, and all of those, and a CARF accreditation or a JACO accreditation of my office space. And so while I have a massive system, not all of our outpatient offices, or actually none of our outpatient offices, are JACO accredited. The whole hospital system inpatient setting is, and all of the other things that are connected with that, day surgeries, obviously all of those things are. But there's never been a mandate for medical hospitals to have their outpatient setting JACO certified, and definitely not CARF certified. Right. But those are just basic requirements to even get in the game for medical health. So I provide a ton of basically free addiction treatment services within our clinic that we don't charge them for because we haven't built the mechanism.
So then how do you interface with the SUD provider that are a higher level, like the level 3, level 4?
Well,
So I'm the medical director I'm the payment medical director.
right.
And so I can say I need them inpatient and they
Right.
just go.
But for the most
That's how
part,
it
the
works.
SUD providers are us because we're trained in co-occurring.
Yeah, but for detox and inpatient stays, then for what we have within our service net, I can call and say, this patient meets requirement, I need them to get into detox.
You are actually the gatekeeper with that system.
Correct.
Yeah.
And that system is actually who we work for, so we're able to screen as well for those and then say these people need to go in.
So I've had several questions that I'm going to challenge you to answer in 30 seconds or less, because I think these are pretty quick questions. So,
We
No
can't.
frickin' way.
okay, Michelle, shall we? So, do you do home visits in your model?
Yes.
Okay. How do you? I mean, is it both of you doing? Just say like 30 seconds on it.
Okay. So, yeah, social work does home visits. We never go out alone. We don't do home visits as often as we'd like just because of the time and the amount of patients we have coming into the office. But if especially when people don't show up or we haven't seen them in a while, we'll go out and go see them.
Okay, so Shelly, how many patients do you see in a day compared to how many Corey sees in a day?
Well, Corey doesn't ever see.
Okay, so prescribers,
Just
the
kidding.
PAs.
We're co-scheduled. So actually, at the most, I would see 8 or 9 patients in a day. We're in hour blocks, and I think now medical used to be in hour blocks. I think medical's now in half-hour blocks.
Okay.
Yeah,
Do
so we
you-
found that, I mean, just for me, when I see, as a attending, I now schedule for touch-ups because my PA teams are doing the vast majority of stuff. So now I'm looking at 20 to 30-minute blocks. And, you know, on a full scheduled day for me, on just a follow-up day, I'm going to see 14 to 18, like a legitimate, you know, beat-down schedule of a day. But because they're being taken care of by the other team, my job is to have listened to the other team and either reinforce the current treatment plan or be the wedge that needs to help move the treatment plan in the direction they're trying to go. Right. And really you can do that in a pretty tight timeline. And then on my Tuesdays, when I'm there, which has been a while, then basically that's when I would do a more structured, like 1 hour, let's figure out what's going on visit for complicated, you know, patients with crossover pain or addiction.
Okay, so how do you manage call on evenings and weekends?
Ignore it. No. Actually, call for behavioral health, surprisingly, is a lot lighter than it is medical because remember we're a primary medical clinic, so even though the majority.
Why don't you sit here? See if that works better.
The cameraman told me, the camera lady told me to sit next.
Oh, right.
It's reflective, and there's 2 pictures of me on the thing apparently, which is going to freak
Oh,
people out.
okay.
Always Corey Waller. So, there's 3 of us, so we rotate every week. So we go on call Friday to Thursday night, Friday. Generally, behavioral health does not get as many calls as medical, but it can vary. A lot of times, because we work so closely together, our medical team will say, can you please call so-and-so, they're in crisis, even though they called through and got the medical provider.
Yeah, we
And
have
the
just
medical
a call. Medical call, so we set up some, we've learned a few things with this because call early was painful. I was on call straight for, I guess, the first 9 months of the clinic being open. And that hurt a lot. And until actually probably 2 weeks from now, I've never been off call. I had 4 days in Mexico in 4.5 years where I've not been at least backup call for that. And that's not a sustainable model of interaction. But on call, once you set up these boundaries, no controlled substances after hours, unless it's an our fault thing. Sometimes something didn't get faxed right or it's in the system or things like that. But no, we're not going to write you for breakthrough pain over the phone. That's just not going to happen. We're not going to call in benzos because you're freaking out. We're going to talk through it a little bit and get the behavioral health provider on. And if you're calling consistently, we always say, is this an emergency? Well, no. Well, it's 10:45 at night and I have children, so I'm just curious, why now? And not in a mean way, but just explain to me why you felt like this. And we use it as an opportunity to make them understand that that's never going to cut it out in a regular primary care office. And in the end, there are times in which I've had to spend an hour and a half on the phone with patients walking around the circle of my driveway just trying to calm them down and do what that is. But it saves an ER visit And the one different concept is that I almost never say go to the ER. My patients will call me and say, I'm having horrible chest pain, shortness of breath, and my left arm is tingling. And I'll say, well, you had a stress test 2 weeks ago that was normal. You've had a heart cath less than a year ago, which showed clean pipes. You've had no risk factors for for you to have a pulmonary embolus. So I think you just need to calm down and relax. It's not your heart. It's not your lungs. That's risky, right? But that's hard. But that's a lot of risk. That's a lot of risk because you know what? It could be a dissection. Who knows? I mean, I'm an ER doctor, so being trained as an ER physician makes me scared to death of everything. That's our job. I walk into the room and I start at the top of spontaneous combustion, and then you move down to PE, dissection, then to acute MI, then to reflux, causing erosive esophagitis where there's a hole in the esophagus, followed by Barrett's tumor that goes. I mean, honestly, these are the things that you think of, and you have to talk yourself out of every single one of those, or you test for it, and that's the training, and that's what it's built for. So it was a big shift to get on the phone with patients and tell them not to go to the emergency department when they're complaining of all the stuff that we all get burned on in the emergency department in your career. Right. So that's a risk of that. That's something I really didn't mention in hiring, but when you're hiring a physician, they need to be comfortable with risk.
So let's just a couple of other quick ones, hopefully. How do you deal with Medicare? Do you do case rates for Medicare Advantage, or are you predominantly working with just Medicaid and not the Medicare, Medicaid population?
I think we do fee for service for Medicare for both
Okay.
behavioral health and all the behavioral health providers are panels.
Someone else, let's get a different one. Someone.
I can just yell.
Here, why don't we try this again?
So we did just have a meeting with CMS about this, and so we are looking at a pilot case rate for primary Medicare, and then anybody who comes from Priority Health or Molina, if they have a qualified health plan, Medicare plan, if they have a managed Medicare plan, or if it's Medicaid or commercial, we still get the case rate. But if they're primary Medicare right now, it's fee for service. But we're just about to start a pilot for that.
Have you looked at the cost of care, including the cost of intervention, or have you mainly just been looking at changes in utilization? Maybe it's me.
No, so we finally, once we were able to get all payer data, that's the thing that's given us actual cost of care data. We're still pretty early in that. We have 2-year early data for a cohort with 1.5, almost 2 years now post. And that's what's showing a pretty consistent 30% decrease if you look at the average. If you take out one outlier, it actually goes to 44%, and that's for 94 patients. And that's what the payer data has shown for that. So we're actually using what's been billed and paid, not just what's been billed. And that's 2 years prior, 2 years post is what we're looking at for those patients.
Okay. Do you ever do groups, like therapy groups?
Not yet. We're working on it. We actually will be starting a seeking safety group soon. Groups have been difficult to get going, both because it's primary medical. Everybody in behavioral health knows you can't mandate people to group unless it's criminal justice, because then they just don't show. And so I think we have enough of a patient population now, and we have actually our new social worker has done a ton of seeking safety groups. So hopefully that'll get going.
Have you tracked how many patients you've lost to follow-up or death due to due to overdose or other causes?
We've had 3 to overdose.
One recently, but we sent her back to the methadone clinic like a year ago.
Yeah, but she's one of the 3.
Okay.
So when we do kind of a postmortem. I guess not literally physically on the patient. This is a high mortality sport. It's a reality of what we do in this world. The problem here is that it's young people, and so this can be very frustrating. And so Shelly and I always have the conversation about we generally don't let stuff rent space in our heads when we go home. That's kind of a unique trait, I think. I think there's not a lot of people who can flip the switch. But there are a couple of patients that we lost I can't even talk about in public. It just kind of early on, learning boundaries and stuff like that. Like I can't even go through the case; it just wrecks me. So, and it's that way I think for the group. And we haven't had anybody that we were actively working on. that I felt like we lost in this pathway. But this is, I mean, you get really close to these patients, even if you set good boundaries, because you see them weekly. And some of these patients we've seen weekly for 2 years. And so when you get to know them and you know their family and you know everything and you've talked them through all this stuff and you've done a lot of work, it's a really tough loss for a group. And so the mortality rate, we've had 7 die total, but we've had 3 die of overdose. And I've looked at the image report on every single one of those and read every piece and looked through and you deep dive into what you could have or should have or maybe could have thought on the best possible day, what you could have done. And at the end, we don't, you look back at little things like, did that email, make a difference in their thought process about using more? Did that one interaction that I had, those wrong words causing that wrong outcome? And your answer sometimes is probably yeah. That sometimes a frustrated Friday afternoon interaction on a telephone caused a Sunday overdose death. So you look back and you look at cause and effect, and you don't cause the disease in which they're being treated in, and treatment can always be made more perfect. It's never perfect, but I think that when you're looking at the mortality rate as compared to those that go untreated, we're way under that. We have a lower mortality rate than the methadone clinic, and it doesn't make it really easier for those specific ones. I mean, I think that you have to be able going into this to kind of know how to turn that on and turn that off, because if you're not able to be empathetic and connected to your patients, it's also you're going to be bad at what you do in this field. They need to feel like you actually give a crap about them, and you have to. And I always say you have to choose what pieces of you want to give them, or they'll choose for you. And so that's a lot of the onboarding, is making sure you choose what pieces of you emotionally you want to give to them, and what pieces of you about your life or your family that you want to tell them about that is okay. I think it's helpful for patients to know that I've had surgery. I think it's helpful for patients to know that I have kids. I think it's helpful for patients, to know that I was seeing them at a time when I had like 8 out of 10 pain in my cervical spine and wasn't really thinking straight because my pain was so bad. So I've had bad pain and I had to have cervical spine surgery to fix it. I followed that up quickly by I still only used opioids for 2 days post-op. And they're like, whatever, I hate you. And
I'm going to go through. One's should be a factual number question, and another's a more meaningful question. So a numbers question for a prescriber, an MA and social work team. What is their panel of patients they'll see for a year, and about what percentage of those can graduate to another setting?
So graduation, we've had probably, I think the last time I looked for people that we would qualify as graduation, because we don't have like some of the short-term high-intensity things have like a graduation ceremony. Our patients matriculate. I mean, they get to the point where they have outgrown us appropriately and just only need to be seen once every 3 months or 6 months, and that's 14% of the patients that we've seen from the start. We've had actually a higher number, 16% when I looked at it last, that have just left us completely. And the rest of them we still have. But again, the people that we still have from the very beginning, we probably wouldn't have those same people still in our modality of care if we had known what we know now. And now that we've onboarded a lot of the early skill sets for, appropriately level setting expectations and understanding what can and can't be done and putting in appropriate boundaries and using medication more appropriately, including opioids and benzos and all of these things, where we've learned how to have the conversation about we're not going to use those and this is why, and to actually apologize to the patient for the health system and what it kind of caused for them, and actually using the same vernacular as talked about earlier about, look, we didn't know, this is what we thought. I mean, I'll actually show them the article sometimes if they want to know it, because they always go to Dr. Google and print something off for me, so I try to give them our stuff every now and then. And I think that looking at those percentages, I feel pretty comfortable with the recidivism. I guess recidivism is the negative connotation to retention. But the return rate is good. I'm pretty happy with that, actually, for who we see.
And so one team, about how many people can they manage at a time?
We're thinking they'll probably maximize between 200 and 300, depending on how many patients they have long-term or not. We're not going to really know, because what we have to get is a total severity score, because I don't think it's about numbers. I think it's about percentage at a level 3 or a level 2 or a level 1. So there's going to be some mathematical equation that we're still trying to figure out of, your total team score is this, and you can't really manage above that because of the numbers of calls and after-hours evaluations and this. So I would say in a perfect world, somewhere between 250 and 300, but it might be only 200 for one team because they just happen to have more level 3s that require heavier hitting stuff, and then the other team may have more level 1s. And so those are still issues we're trying to work through.
Can individuals with severe early childhood trauma have their neurobiology rejiggered to lead meaningful lives?
Shelly?
I was just talking about this briefly. The short answer is yes. And the longer answer is, I guess it depends on the extent of trauma, how it impacted their brain, if there's any early onset addiction and or pain or both. So, but even if someone quote unquote has a broken brain, you can still work with them to better manage emotions and learn skills.
Can you briefly run through, who we're talking about? Miss Cluster B calls every day, but how well she's doing actually in outside life?
Right. So this is a really good example of a patient who has early life trauma starting from pretty much childbirth through age 18. Now I've been in the field with this population almost 20 years now, and this is by far the worst sexual abuse history I've ever heard. Part of which she still sees one of her abusers on a regular basis, which just kind of keeps that trauma cycle going. So a female, incredibly awful early life trauma, a ton of abdominal pain, very, very highly somatically focused, because the only time she ever got any validation in her life was when she had a medical issue, and when she had a medical issue and went to the ER. The reason why she likes to go to the ER is because they pay attention to her, because they touch her in a safe way, and they validate her and tell her that whatever she's saying is what's going on. So that says a lot about our primary care system. She is a very, very challenging patient, I'll give you that. She is incredibly challenging. Even in our clinic, she's been with us 3 years, she still has the highest call volume. I mean, we've really had to set, we've set boundaries recently where she can't call after hours. That may need to be looked at again, because I'm not sure if that's beneficial over the long run, but she was just calling because she needed advice, and that's just not appropriate no matter how many times you set those boundaries. Anyway, doesn't really have addiction issues, still highly somatically focused, works full time but doesn't keep a regular job because she calls in sick because she has all this abdominal pain. Was married twice, both abusive men, couldn't ever have sex without vomiting, was basically afraid to feel anything because emotions are not safe. So after 3 years, she still goes to the ER, not as often, but she still does.
Her total volume decreased by 74%.
Okay, she doesn't go to the ER nearly as much. She still calls every day. She still has chronic abdominal pain that is, she was diagnosed with a mild case of Crohn's, which is now in remission, but that hasn't gotten rid of her pain. But she has had sex with a male, because she's not interested in females, even though we went down that road because men have always treated her horribly, without vomiting, and actually enjoyed it. And she punched a hole in her wall the other day because she was really angry, which I don't know how many of you have patients out there, but I was like, oh my God, that's the best thing I've ever heard. I was like, I am so proud of you. That is incredible.
Yeah, that, and she's actually finishing her bachelor's degree.
She just finished her bachelor's. Yes, I forgot about that.
And so there's a person who can still get stuff done, but is requiring really high touch. Mm-hmm. And so what drives us insane internally, I mean, to the point where I can't see her because she realizes how frustrated I am, and I'm frustrated because I can't fix the problem, and I'm a fix-it person. And so I don't see her anymore, because even if I'm trying to be and am empathetic, she is very emotionally adept, and it takes one sideways glance, one half roll of my eyes, or one little anything. So I don't go down that road with her. And so we've decided that it's best that I'm not involved in her care, in the clinic, and there are plenty of patients with significant early life trauma in which I've been a positive role model for them in kind of a fatherly, like this is a normal, appropriate way that you interact with a male in a professional setting kind of way, but it's just not for her. And so that's been recognized by the group, and it's stated that way. And each of us have one or two of those patients that we no longer see. And in fact, when they're in the office, we just make ourselves scarce so that they don't see us. And we all have those, the ones, and we have the types that we are bad at. I have a subtype that I just can't see. They drive me insane. And I can't, and it's weird, it's frustrating because I like having significant control over my own emotions, but in this group I get, it's really difficult for me to not get angry because it's these people, it's a group of patients who have low IQ and zero capability for logic. So, none. And so I would say, well, we had a study that showed this, and we gave you this, so this is the outcome. Well, they faked that study. No, they didn't fake the study. That was you were there for it, right? When they put the ultrasound on you, you were there, and they took pictures, and those are the pictures that ended up. And no, they made it up. I understand that you don't trust the system, and I get, so you go through all of this, but by the end of this, it's a rabbit hole, and I always go down it, and but you become really self-aware about the areas that you're really bad at as a human being, and it's a little frustrating, because there are days in which you go back, and you had one of those days that I was a terrible doctor for those patients, and that's a reality. And so understanding how you build these systems means that it can't be a one-person thing, because that means that if it's one person, then there's a subset that literally they're either going to be bad at and make them worse, which if I was the only one that saw them, it would actually probably escalate their behavior and make it worse. So you need a team for that reason, and I think that that's important. But that patient is a huge one because she's doing so well on the outside, but I wouldn't know it because all I hear is I look at the call volume sheet and I'm like, ugh, again.
She's probably someone that does have significant long-term brain issues from trauma and may never ever, quote unquote, be normal, but she's someone who we've been able to help manage emotions and take steps to make her life better and more functional and actually act out in a healthy way.
Well, thank you. I want to thank both of you for joining us and spending the day with us. Let's give you a round of applause.